Welcome to the Journal of the American Society of Echocardiography podcast. Editor-in-Chief Michael Picard, Managing Editor Deborah Meyer, presented myself, Dr. Amr Johri. Today we will be talking about the recommendations for echocardiography laboratories participating in cardiac care, ultrasound, POCUS, and critical care echocardiography training, a report from the American Society of Echocardiography. Online today, we have Dr. Michael Lanspa joining us from Utah, and we will also have Dr. James Kirkpatrick joining us during this podcast. Cardiac point-of-care ultrasound provides rapid bedside diagnosis of important cardiovascular pathology and is performed by a growing number of users in a variety of clinical settings. Echocardiographers and sonographers may be asked to play a role in training practitioners in cardiac ultrasound who come from disciplines outside of the cardiovascular field. These trainees' backgrounds, needs, objectives, and available time can create challenges and opportunities for echo labs. Furthermore, the presence of additional learners in the echo lab will require additional resources. This document is the product of the ASE writing group composed of representatives from cardiology, critical care medicine, emergency medicine, and cardiac anesthesiology, and others, assembled to provide expert guidance. The following recommendations are intended as practical resources to assist echo labs to train partners in the provision of high-quality cardiac ultrasound, including identifying training needs, employing educational resources, in general avoiding certifying global competency, counting the cost in echo lab resources, and advocating for resources to meet extra needs. So today, it is my pleasure to have Dr. Michael Lanspa and Dr. Kirkpatrick joining us.
Thank you for having us.
Great.
Thank you for having us.
Thanks for joining us, gentlemen. So today, what we're going to do in today's format is discuss the guideline and listen to your points as to why you think this is an important contribution to the literature and why this was needed. Of course, these are uncertain and unique times, and I feel that this guideline is especially relevant in this day and age because of the COVID-19 infection that we are continuously hearing about. This is an example of a ultrasound, a point of care ultrasound of the lung in an infected patient, and it really brings home the relevance of this guideline. So before we delve into the guideline, I just wanted to quickly take a look at this point of care ultrasound of the lung. Dr. Lanspa, are you able to comment a little bit about what we're seeing here?
Yeah, of course. So what you're seeing here is lung ultrasound, which has those vertical lines that are going down are called B lines. And what those are is actually reverberation artifact of the interlobular septa between the two lobules in the lung. You're seeing that bright horizontal line, that's the pleura. And what this is suggesting is that there is some sort of extravascular lung water which could be cardiogenic or non-cardiogenic pulmonary edema. We see the same finding both in ARDS as well as cardiogenic pulmonary edema. And these findings are also present in a large percentage of patients with COVID-19. In fact, lung ultrasound may be very useful since a majority of the radiographic findings suggest that the inflammation or edema is peripherally located.
That's great. I think it really brings home the importance of this technology and how we have to think about training as well as safety measures. So it's a great context for us to discuss the guideline today. So I'm going to move over to the actual recommendations, and Dr. Kirkpatrick was kind enough to develop a brief PowerPoint that I'm projecting here. Dr. Kirkpatrick, I'm going to run the PowerPoint from my end here, if that's all right, and record your comments on that. Does that work for you today?
Absolutely.
Okay, great. So bringing back to this context of the coronavirus and the role of point-of-care ultrasound, can you tell us a little bit more about this?
Yes, thank you so much for the opportunity to share this, and I thought it was a great idea to actually illustrate how point-of-care ultrasound can be specifically helpful in this disease to diagnose lung findings without a chest x-ray, and the idea there being that the radiology tech does not have to be exposed to assess the lungs. But this is also true, I think, in the setting of cardiac POCUS. If a practitioner is going to be going in and seeing the patient anyway, performing a POCUS examination that may obviate the need for echocardiography performed by a sonographer or other physician can actually be very helpful in limiting the overall exposure of healthcare workers to COVID-19. In addition, using large machines becomes a cleaning problem because they have lots of nicks and crannies, and it is much easier to clean smaller machines and make sure that they are sterilized and are not transmitting virus between patients. Furthermore, it is very possible that sonographers, who can be a scarce resource, may become more scarce if some of them are exposed and become sick, or even if they develop upper respiratory symptoms for some other reason, end up having to take off from work. So the use of POCUS may be very helpful in this setting. Personal protective equipment, of course, we all know is a scarce resource even now, and probably going to get even more scarce. So having one person seeing the patient and performing the examination can help to conserve our resources in this respect. Furthermore, we are working towards this at the moment. These primary clinicians who are already caring for patients suspected or confirmed with COVID-19 can actually help us to do better full feature echocardiograms, because full feature echo will still be needed to measure certain things or do a more in-depth examination. Having a POCUS exam performed first may actually help to keep the sonographer in the room for a shorter period of time. They'll know what they're going to be looking for, and it will actually be helpful for them in targeting their exams. The one caveat to that is that POCUS users may end up spending an awful lot of time trying to find the right views, and that could actually put them at higher risk than if a sonographer just came in and got the views very quickly and answered the clinical questions. So all of these things need to be balanced.
That's a great point. Dr. Lanspa, what is your experience from the critical care setting and the use of critical care echo in this context?
Well, fortunately, at my institution, Utah is just now starting to get our COVID patients, so we haven't had the full onslaught. But I've been in contact with some colleagues at Italy in the Lombardy region, Simone Piva, who's an intensivist at University of Brescia, who's commented that they've basically configured POCUS and full echocardiography into part of their workup of the most severely affected patients with COVID. They're finding that a large number of these patients end up having pulmonary embolism, a sizable number have pericardial effusions. And then I've also been in contact with, actually she's the chair of the Society of Critical Care Ultrasound, Society of Critical Care Medicine Ultrasound Committee. That's Sarah Nikravan Weber, and she's an intensivist at University of Washington in Seattle. And the interesting thing that they've done is they've put point of care ultrasound in the room. They've assigned some of these point of care handheld ultrasounds to the room to avoid having to clean it and have it a vector going between patients. So they're at a point right now where they can leave some of these in the rooms of the sickest patients. So when they need to do a quick bedside assessment, there's decreased chance of them bringing that probe in and out of the room.
That's a great idea. So it's as if that device is dedicated to that patient.
Exactly.
Great.
Yeah, we are hoping to get a number of these devices. Of course, you need quite a few of them if you're going to be able to do that. But even just with a few, it is possible to reduce transmission if they can be at least segregated to a certain area of the hospital where the patients are going to be. And it does raise the question of whether other ultrasound equipment should be sort of dedicated to COVID positive patients so that they are not used on patients who don't have it and risking infection transmission there as well.
What do you guys think about things like sterile sleeves? Is that useful or not? Would that impede imaging? Would that help with protecting against crevices?
We actually are going to be using those in those POCUS machines. And in some cases, especially if it's used with an iPhone, or not an iPhone, but with another type of smaller device, sometimes that device can fit in the sleeve as well.
Yeah, my concern is basically, I think the sleeve is fine, but it's very difficult to guarantee that you are going to keep that area sterile, and so you would still need to clean the probe regardless. And
Yes.
you know, one of the great pieces of advice I've gotten from one of the intensivists at University of Nebraska, Dan Johnson, is, you know, even we should kill COVID-19 regardless of wear and tear on the transducer. So even if you have a harsh cleanser, I've yet to see a transducer taken out of service in a point-of-care ultrasound due to harsh cleanser. They all die from someone dropping the probe or smashing it or running over the cord before bleach or any other aggressive cleansers kill them. And even if they do get ruined by bleach, that's way better than transmitting a disease to a patient or a healthcare worker.
That's a great point. And then the final nitty-gritty aspect would be the gel itself, and whether you know, that it's a water-based gel, but whether the virus can exist in the gel, and wiping it up and making sure that that's not transmitted outside of the patient's room.
Gel is cheap. It should stay in that room. I mean, you get one bottle of gel per patient, it stays in that room.
Yeah, our current practice at the University of Washington is actually to do a thorough cleaning of all devices inside the patient's room, then move the machine out of the room and do it again once it's outside the room.
That's a great point. Okay, well, I think it is still, as Dr. Lanspa mentioned, early days in terms of the use of point-of-care ultrasound for lung. And I think we're going to expect to see more cases. Dr. Kirkpatrick, there's also been some reports of the virus affecting both cardiac patients that have pre-existing disease, and perhaps initiating a cardiomyopathy. What are your thoughts on that and the role of point-of-care ultrasound?
I think both of them are probably true. My understanding of our knowledge about this at first, and I'd certainly welcome other input on this, is that most of the really fulminant cardiac involvement is at the end stage, and it's somewhat controversial whether there is a direct cardiotoxic effect apart from sort of multi-system organ dysfunction. And I think we'll know more about that as things progress. But it's certainly true that older patients are at risk and they tend to have cardiac disease. So certainly that is a major factor in all of this. I think we have to be a little bit careful about using all resources that could put healthcare workers at risk in terms of expecting things or over testing, as always, and not all of our testing should be appropriate. But in this setting, I think that POCUS has a good chance of giving us more information, helping us to understand what the heart actually is doing in the course of this disease, especially in patients with underlying cardiac dysfunction.
Yeah, my colleague from Seattle had commented that one trend that they've noticed among the patients who are dying is often they'll have hypoxic respiratory failure, they'll be intubated, and they'll be able to maintain the oxygen on the ventilator, and they will start to look like they're improving from a gas exchange standpoint with normal ejection fraction, and then at some point they will have a significant drop in their contractility with ejection fraction of perhaps 10%. And so, as Dr. Kirkpatrick said, you know, it seems like this cardiomyopathy or cardiac failure seems to be happening fairly late in the presentation.
Great, thank you for those important points. And this drives home the potential role of point-of-care ultrasound given the advent of this disease. And of course, the recommendations and guidelines that we envisioned initially were started before this changed landscape, but does provide good context now for us to delve into the specific guidelines. So I'm going to move to that now. Does that work for you, Dr. Kirkpatrick?
Yes.
Okay. So let's begin with the definitions proposed in our recommendations that are now published online at the website of the Journal of the American Society of Echo. Dr. Kirkpatrick, can you take us through these definitions?
Certainly. I should say at the outset that there are many, many different types of definitions, and as our committee was considering what to call things, we did settle on this, but we recognize that there are other ways to conceive of all of these categories and certainly other terminology as well. In general, we wanted to differentiate UAPE, which stands for Ultrasound Assisted Physical Exam, a routine performance using a relatively limited imaging protocol that really just augments the bedside examination. And in UAPE, there may not be the expectation of saving images. One would hope that the findings would be recorded in a progress note, but it really is just an extension of the physical exam, as has been used in other terminology. That we differentiated from cardiac POCUS, and in cardiac POCUS, we believed that that would be best defined as a focused exam using a specific imaging protocol or protocols, and this was based on the suspicion of a specific disease, such as ruling out tamponade or attempting to see if there's LV systolic dysfunction. In many cases, the images will be saved, especially for quality assurance purposes, and there will be some kind of report. It might just be in the progress note, but it might also generate an actual report that goes into the electronic medical record. CCE is critical care echo. This is a different situation because these exams are focused on the views and findings that are pertinent, especially in the care of critically ill patients in the emergency department, in some cases, and in the ICU. This might include Doppler investigations to be able to calculate cardiac output, and certainly assessments of fluid responsiveness, which have been reported in the literature for a very long time. This is necessarily more involved than cardiac POCUS, although some advanced cardiac POCUS may approach the level of detail that a critical care echo does. It certainly involves the generation of a report and the saving of images, especially because one of the advantages is being able to compare what's going on in a critically ill patient over time. So you certainly want to be able to see over time and compare images over several days at least. We differentiated this from limited echo, although admittedly some limited echoes are in a scanning protocol really quite similar to cardiac POCUS and critical care echo. But limited echo is focused on certain aspects of the cardiovascular exam, especially those that were seen in a previous comprehensive exam. And this protocol is answering a specific question or a few questions. This is really the definition that the ASE has been working with of limited echo for quite some time. One of the important aspects of a limited echo, however, and how it is differentiated from cardiac POCUS and CCE, is that it can be converted as needed to a comprehensive echo, because you have the sonographer there, and they can certainly employ advanced techniques such as quantitation of valvular function, strain, 3D, other things that are involved in the comprehensive echo, and those can be done right there at the bedside as needed. I've already sort of given the overall view of what a comprehensive echo involves. Of course, it doesn't always involve strain 3D and other advanced techniques, but in general, it does look at the entire cardiac system. All the findings are reported, and a report is generated, and obviously all of the images are recorded and archived. So again, recognizing that there are different ways to look at this, this is basically how we were assessing the field.
This is great. I think it really lays out the spectrum of the way ultrasound is being applied in the cardiovascular field. Dr. Lanspa, did you want to comment?
Yeah, I think that this is basically recognizing that there was an unfulfilled need, you know, a decade or two ago, where people wanted some way of getting rapid information, and so these people sought to get some training, and that's where you got that UAPE, the the ultrasound assisted physical exam. And as you got more sophistication, people started learning more and more about this, and you're seeing a large number of intensivists and emergency room physicians who are becoming echo enthusiasts. In fact, you're seeing a lot of people who are trying to learn more and more about comprehensive echo because they find the value in it.
Great. So I'm going to move on to the next few slides, which basically talk about the identification of training needs, employing educational resources, avoiding certifying global competency, counting the cost, and advocating for resources. All of these sections are detailed very well in the actual document, which is now available online at the JACE website. What we're going to do today is go to some of the main figures from the paper so that we can hear from the authors now that we have them here online with us. So this is a great figure that shows the stepwise training requirements. Dr. Kirkpatrick, can you briefly comment on this nice figure that you developed?
Certainly. One of the things we realized early on was that we didn't want to provide the same training experience to everyone, regardless of their background and their needs. And so we advocate really sitting down with the trainee and trying to figure out what it is that they need. It might be something that's very well spelled out by their training program, but it may be something that is actually determined in a discussion about what it is they're going to be using cardiac ultrasound for. And that's really the first step. We want to give people what they actually need, not necessarily pigeonhole them into a thing that is not going to be helpful. Next, we're hoping that it will be possible to assess their experience category. And there's a variety of ways to do this. We'll talk about it in some of the later figures. But essentially, we have to target our training experiences to where people are at. Some people are very early on and very novice. Other people are really quite experienced. And we don't want to waste people's time, either by giving them something that's too advanced or by going over something they're very well versed in already. The next step up is to determine objectives and time frame. And obviously, again, this may have a lot to do with objectives that they've already been given by their training program and the time that they have been allotted for training in the echo lab. But I think it's important to actually go through this and determine it and figure out what is actually going to be the best use of time and what kind of ways are we going to give them the education that they need. And then finally, we thought it was very important to explore and correct any misperceptions that people may have. People coming to the echo lab don't necessarily know what it is that we do, and if they're very early on and they're training in cardiac ultrasound, they may have some misperceptions about the role of cardiac ultrasound, the limitations of cardiac ultrasound, the limitations of the specific transducer or machine that they're using. And of course, there are perceptions about being able to get good really, really quickly because it looks so easy when the sonographers do it. And it's really important to explore these and make sure that people are on the right footing as they're moving into cardiac ultrasound.
That's great. And this is where you give a little bit more detail about the definitions of the different types of training.
Yes, we wanted to acknowledge that some people come to the echo lab simply as observers. They're not necessarily going to be using cardiac ultrasound in their practice, but it is helpful for them to know what echo is, what echo does, and I think in particular it helps them to order more appropriately. There are practitioners who come with some informal training, may have been non-systematic. but nonetheless, they have some familiarity with it. And of course, now there are increasingly courses and rotations in medical school and other settings and conferences that have provided some limited formal training. And then there are formal training programs, particularly in emergency medicine, critical care, anesthesiology. And these learners are actually very experienced. They may actually be quite a bit better at scanning than maybe some of the cardiology fellows. And we have to acknowledge the fact that they already know a lot and can do a lot. And really what we want to do is take them to the next level.
Great. So Dr. Lanspa, can you comment on some of the formal training experiences achieved by non-cardiology trainees?
Yeah, of course. So a lot of people will go to a 2 or 3 day course to get some introduction to it, where they do some hands-on training, they get a bunch of lectures, kind of drinking from a fire hose. And then a lot of those people will want to get additional training. Now, emergency medicine, I think, is actually the leader in this, in that they have basically made this part of their standard curriculum. Whereas critical care and anesthesia, they've got a lot of experience in certain centers, but there are a lot of programs that have no formal pathway to have this sort of training. In fact, if you look at internal medicine and pediatrics, both in critical care or non-critical care, there is a dearth of expertise for training. And so there's a big desire for this formal training, but there's actually not a lot of people who are qualified to teach. Emergency medicine has mandated this to the point where they've actually got a decent number of physician trainers who can offer a formal pathway, but still it's not as echo heavy as you might expect. They're going to be doing joint ultrasound, they'll be doing some echo, they'll be doing some lung ultrasound. But the big value, I think, of this document is to try to address that need where you have a large number of people who actually don't have formal training, but a desire to get formal training.
And many of them are going to be coming to the Echo Lab, so we need to come up with a way to help them with this training. And so this is a great figure because it tells us in terms of what are some estimated time for training, as well as numbers of exams. So Dr. Kirkpatrick, can we get you started again on this figure?
Certainly, and there is some evidence to support this. Much of it has been produced by Bruce Kimura, who has been working in this field for a very, very long time and is an author on the group and has contributed a lot to looking at training and length of training and that sort of thing. Again, we want to acknowledge that some people are observers. They're just coming in. They need an introduction to echocardiography, and then they need some observation experience. These numbers are sort of just a general guide to give people, again, that observer experience. They're not necessarily set in stone. For ultrasound-assisted physical exam, we actually recommend the medical student novice curriculum that was produced by Dr. Johri and his group, and really goes through a very comprehensive and yet easily digestible online presentation of medical student and novice focused understanding of cardiac ultrasound and basic views. In order to supplement this, we recommend 2 weeks of hands-on training, and then also putting together what we call a portfolio, and that is exams that are proctored or somehow overseen by an expert, and go through the protocol, save the images, have them reviewed, generate an interpretation, and have that in your portfolio. It should be noted that these should not all be normals. They really should have a breadth of experience and exposure to different abnormal things, ideally what the person is going to be experiencing in their practice. Bruce has really made a great point in finding that the way that cardiac ultrasound works is use it or lose it. And he and others have demonstrated a loss of skills over time if people are not able to do at least refresher courses or don't practice this on a daily basis. And so we recommend that people do come back for some refresher course. 10 proctored exams would be a good way to do this, but there are other ways as well. For cardiac POCUS, again, we recommend Dr. Johri's online curriculum available on the ASE website for free. And we think about 1 or 2 weeks can be helpful in gaining this training. Again, it depends on the patient, on the practitioner's former training and their needs. We do recommend more exams that can be part of the portfolio, and being able to compare all of them with full feature echo. There was a bit of controversy as to whether these should be compared to other limited exams, but we felt that comparing to full feature echo gives the learner a good sense of what it is they're able to see and what it is they're not able to see, and the limitations of the POCUS examination in comparison to the full feature echo really helps people to see the continuum of ultrasound and how full feature echo may be necessary to define certain findings. Again, we recommend refresher courses. And finally, for critical care echo training, there's actually some work that's been put into this from the National Board of Echocardiography, which now offers certification in critical care echo training on a board exam. And this, the NBE actually has an extensive list of all of the different findings that critical care echo people should be trained in. We actually include that as an appendix to the document. But we are also in the process of publishing a curriculum from the ASE that goes through many of the cardiac-only findings that are a bit more in-depth and goes over both interpretation, or scanning and interpretation. There are many other curriculums that have been developed which are also very, very good. The amount of training time we think should probably be in the 2 to 3 month period. Again, it depends a great deal on what the prior experience has been. And then the NBE has set this number of 150 examinations with image review and interpretation in comparison with full feature echo. And again, we emphasize the importance of refresher if the practitioner is not doing this on a daily basis or is doing it infrequently.
Great. Dr. Lanspa, can you comment on the how many numbers of trainees are pursuing this? Can you give us a ballpark figure of the volume that we may be expecting?
I think that this is a general statement about all physicians, is if you give them a test, everyone's tripping over themselves to see who can be the first to take it. But in the critical care arena, I can tell you the 2019 was the first year that the exam was offered. And so far, there have only been 25 people who have certified in this, although there's been about 450 people, I believe, who have taken the test, and one of the big limitations here is getting that 150 proctored exams. And part of that is because a lot of people who took it are going through this practice pathway where there's a little bit more challenge in trying to get these proctored exams. Trainees, on the other hand, I think are very interested in doing this, and there's a much easier pathway for them in that they can do it while training. We've had a couple of fellows at my institution who have expressed interest in this, one of whom did train and did her 150 echoes, and I think she's one of the first fellows to be board certified. Now she's an attending. But one of the things I want to emphasize is that 2 to 3 month period. For a lot of the people who are going to take this test, they're going to spend considerably more time than 2 to 3 months. So while that may only be 2 to 3 months with the echo lab, they're probably going to be spending somewhere to 6 months to a year doing training on this. And so that may be something to also consider. One other point I wanted to make is I think the importance of having that portfolio is key, because if you have people who are only doing 1 or 2 weeks of training and they want to see pericardial tamponade, they may not come across a tamponade case during those 1 to 2 weeks. And so having a great teaching case of tamponade or a great teaching case of hypovolemia is going to augment their training. But I can tell you, I've had so many people email me and call me about how to go down the training pathway. This is something that I think you're going to see nationwide. Intensivists are going to be looking for this, and unfortunately, there's not enough teachers at some of these institutions to provide that expertise, and so people are going to be looking for the Echo Lab to help offer some of that training.
Okay. And what it qualifies as a proctor in this context?
So the proctored exams are typically done by, it depends. If you're in the practice pathway, it needs to be done by someone who is board certified in the comprehensive or perioperative echo from the National Board of Echo. If you are a trainee, it can actually be done by it can be signed off by the program director, but it has to be supervised by someone who is deemed competent. There's also the ability to have a proctor expert be a tester of the comprehensive examination and also someone who is recognized as an expert in the field. So they've made exceptions for people who have passed the exam but are not cardiologists and are testimers but recognized as knowing what they're talking about.
Okay, so that can also be a potential rate limiting step for people to follow this pathway. Thank you. So this is an important figure from the manuscript as well, talking about some of the errors and misconceptions that can occur. Dr. Kirkpatrick, would you mind taking us through this figure as well?
Yes, and again, it should be emphasized that particularly critical care echo trainees who have spent a lot of time doing it will probably be less likely to be falling into some of these misconceptions, errors, but I don't think we can necessarily make that assumption, and it is important to elicit this and then move in the appropriate fashion. To be honest, probably some of our cardiology fellows should be assessed for this as well. The misconceptions that we wanted to specifically address were, as I mentioned before, this idea that you can achieve mastery of echocardiography really quickly. Sonographers do make it look easy, but it's not. And anybody who's put their hand on a probe on a difficult patient knows that that is the case. And I think it's important that people understand that that is the way it is, and that even the number of scans that they may be doing early on with normals does not mean that they're going to be able to do this on difficult patients, especially those that are intubated in the ICU. The other thing that we wanted to emphasize is that just because you completed a training course, it doesn't mean you're competent. Competency is something else. And increasingly, all of the cardiology training ways of thinking emphasize the fact that competency is not necessarily about numbers, it's not necessarily about time, it's certainly not necessarily about completing courses. And so really it's we need to be focusing on whether someone can do it, not necessarily how many times they've done it or how much time they've spent doing it. The errors, I think, are well known to everybody from in echo labs, missing a finding when you're doing imaging, or the finding is actually there, but you miss it when you're doing your interpretation, and then of course mistaking something and ending up with a misinterpretation, something that even at the highest levels of echocardiography we're all need to watch out for. The committee developed certain points of emphasis that we needed to think about that need to be emphasized to learners, and again this applies I think to seasoned cardiologists as well as the first-time person looking at an observer status in the echo lab. We all need to be aware of the appropriate indications for echocardiography as well as cardiac POCUS and critical care echo. Again, they're not all the same. They're used in, they're different tools and used for different things and oftentimes looking at different aspects. We also need to recognize the limitations of our devices. The hand-carried devices have become really amazing. They are able to produce wonderful images, but they are still not as good as the full-feature machines, and we have to realize that. We have to recognize our own diagnostic limitations, both in scanning and interpretation. Even if you're a natural at scanning, or even if you understand a lot of what's going on when you look at images, there are still limitations, and one always has to be cognizant of that. We also want to teach avoidance of exclusive reliance on cardiac ultrasound findings. I think this should be axiomatic for all of us, that one test does not a diagnosis necessarily make in many circumstances, and even if it does, we have to put it into the clinical context. And I think this is part of avoiding hubris in all diagnostic testing. And then finally, we believe very strongly that our trainees need to know when it is appropriate to order a comprehensive echocardiogram, and to probably have a relatively low bar for doing that when there are any questions of what they're seeing and whether the patient could actually benefit from further elucidation of the findings that they're coming up, or if they actually don't find anything and the clinical situation suggests that there is still a cardiac problem, they need to move on to the next test and actually have a good relationship with the echo lab that allows them to do that.
Thank you, Dr. Kirkpatrick. I think this document really balances out both the advantages and limitations of training in point-of-care ultrasound and cardiac ultrasound in general. There are important limitations and pitfalls that educators and trainees need to remember. So this is a great figure. So I'm going to move on for the sake of time. Resources, did you want to mention this was the resource that you had talked about previously that's available on the ASE website for free and is a starting point. So who do you feel would benefit from this starting point resource?
To be perfectly honest, I think probably everyone could benefit from it. It is very, very comprehensive in going through the basics of cardiovascular point-of-care imaging. It was designed for medical students and novice users, but I really think that this is important for POCUS users. It's a great refresher even for people who have been over this curriculum before. As you can see, it's divided into a number of very helpful and modular components. So if you feel that you got your basic anatomy down that's related to the cardiac views, you could certainly go on to some of the other things. The pathology in both sections are very helpful to be able to show what sort of things you can uncover with POCUS. And then there's this very unique section on teaching the teacher, which goes through the number of different things that you need to plan out in order to be able to train point-of-care ultrasound novice users. And then it provides some standard and some testing and some questions to go through as well. So I would highly recommend this. To be honest, I think this might even be very, very useful for first-year cardiology fellows just coming into the echo lab.
That's great to hear. There's also an introduction to lung POCUS here as well. Some initial images and introduction to that, which I think is a field that perhaps not only non-cardiologists are interested in, but also your traditional cardiologist is getting into as well, especially in terms of assessing patients for heart failure, for example. There are some other resources available through the American Society of Echo, which I would highlight here. And the document talks about all of these important points. For the sake of time, I won't go through all of these key points. But I think this is an important checklist for echo labs considering expansion of the ultrasound-assisted physical exam, POCUS, and CCE training. So Dr. Kirkpatrick, can you briefly take us through this checklist?
Absolutely. One of the main things that we realized was the need to, in a sense, count the cost if we're going to be participating in these training. And so we came up with 10 different questions that we all need to ask ourselves. And I think it's important to do this because we need to be able to provide a good experience. And we need to be able to provide an experience that doesn't conflict with our other educational responsibilities or with clinical care. So we encourage every echo lab before embarking on this, do you have enough equipment? Do you have enough server space to archive images that the trainees are going to generate? Are trainers available to teach scanning and interpretation skills? And then if you are going to enter into this partnership with people who are performing this, particularly critical care echo and POCUS, are they going to need some off-hour scanning assistance or backup? In many cases, that answer will be no, because they already have experienced people in their department doing this, but in some cases they might. Is there opportunity for review? And is there training available in extracardiac imaging? It cannot be certified in critical care echo without this. And if you're not able to provide it in your lab, then they have to find it somewhere else. As we mentioned earlier, you've got to have adequate exposure to the clinical findings that they're going to be seeing. You really can't have people seeing all the same thing or, God forbid, normal echoes all the time. And then, as I mentioned earlier, we have to make sure that the resources are there to meet the needs of these trainees, along with cardiology fellows and sonography students, if actually your lab is participating with them. And then finally, we all know that quality assurance is important for us, and it's certainly important as well for practitioners of UAPE, POCUS, and critical care echo. And it may be that they have quality assurance and quality improvement programs already, but if not, then we need to ask whether we're going to be able to supply that for them.
Great, this is a really important checklist. Dr. Lanspa, I know you've been interested in quality control in CCE training. Did you want to comment on this as well for us?
Yeah, of course. I think one of the things that is a key in maintaining a good critical care echo service is to make sure that you actually have someone who's doing a reality check. I work at an institution where I have, let's see, five people who are testimers of the comprehensive exam, and two of whom are certified in the critical care echo. And yet we still have monthly meetings where we go over our echoes, and we're basically reviewing images, reviewing quality. We have an advanced cardiac sonographer who also does research with us, who is usually in attendance. But one of the ways that we maintain quality is to make sure that we have a monthly meeting where we review these echoes. And I'm also offline reviewing a lot of these echoes after the fact as well, just to make sure that we don't have anything that looks inappropriate.
Great, thank you for that. So I'm going to end with this final figure here before I open it up to some questions. I think this really is a nice pyramid that talks about all of the issues in terms of quality assurance and machine support on the base, along with IT support, and then moving towards what basic training services comprise. The manuscript generated by Dr. Kirkpatrick and Lanspa and the group is really good in that it provides echo labs with guidance as to who are the learners coming to the echo labs, how much training we need to provide them with specific details and timing and what kind of training, where it begins and where it ends. It also provides resources. So I think this document is going to be very helpful for echo labs, and I encourage our listeners and readers of the Journal of American Society of Echo to really delve into the contents of this guideline. So before I end there, I'm going to ask some of the people who are joining us today to also ask questions. I know Dr. Ritu Taman is online, so I'm going to just check in with her. Ritu, are you online?
I am. Let's see. Can you hear me?
Yes, we can hear you quite well, Dr. Taman.
Okay.
Are you able to provide any comments or questions for our panel today?
Thank you for the opportunity. It was wonderful presentation and thorough going through this wonderful guideline. I do have a question as it pertains to the COVID-19 infection, which we are seeing increasingly across the country. And that is, are we going to be recommending using this as part of the initial physical exam to avoid perhaps doing a more full echo down the road? I don't know the answer. I don't know if it's being done, but as a screening tool, it seems that it may be an opportunity for us to decrease the morbidity associated with this disease?
So that is a great question, and I can tell you that actually it is being done as part of another ASE endeavor to generate a statement on COVID-19. We were reviewing some of the protocols at a number of different places, and some of them specifically say that POCUS should be used to triage full feature echocardiography.
Wonderful. And I know that Seattle has seen probably the largest share of patients to date, and there's a real concern about the myocarditis feature, which is seen pretty late on the disease. Is there anything that you have observed apart, like RV dilatation early on? Any echo features that you might have observed that point us, that gives us a heads up that we might be heading in that direction, apart from these rapid atrial fibrillations that we're seeing, and then of course this VFib and death. But
I've asked that specific question to Seattle physicians as well as those in Italy, and I've not gotten any clear indication from them. I personally have not, I can't answer that question with my own experience, but relaying what they've told me, they have not found any clear, clue that might predict who might be likely to fail. The description that I keep hearing is looks good, and then as the patient starts to improve their oxygenation, then something happens. And yeah, they've not been able to clearly associate some sort of predictive value. But keep in mind, one of the other things is Italy is right now in such turmoil, there's barely any time to do any research. Right now, they're struggling just to keep a registry of data for a lot of these hospitals. So we may find this out after the fact, or perhaps a month or two later, that there may be some clue that's just not being picked up right now.
And that leads to another question. Is there a registry that we have within our ASE that, as we start to see more of these COVID cardiomyopathies and myocarditis, is there a way we can register them so we can get the information in real time rather than, months later?
We don't have a POCUS registry at this point. We do have some centers that are participating in a echo registry, but that question has not been brought up to my knowledge. Would you agree, Dr. Kirkpatrick?
Yeah, and I think it would be real value in doing that. We are still quite early on in this, and so I think a lot of the reason that we don't have a lot of information is that we just don't have a lot of echoes or cardiac ultrasounds performed in this setting. Evergreen Hospital, which is kind of the epicenter in Seattle, does not have a lot of experience from the cardiovascular standpoint. They have a lot of pulmonary experience and ICU experience, but not a lot of cardiovascular experience. And I think that in part of what Dr. Lanspa said, that patients decompensate so quickly, and there's not always time. There's always obviously some barriers to performing echocardiography in these patients who concern transmission and things like that. So I think this is where POCUS has a real opportunity to be able to collect some data and see what is going on, and then there may actually be some signs early on that that will herald the decompensation or put people at risk. There may not be, but it would be nice to know that. And then obviously, as hopefully treatments become available, there will be options for looking at the cardiovascular effects or prevention of bad cardiovascular effects. And under the rubrics of attempting to reduce infection, I think that POCUS has a great opportunity for this. So if ASE or other organizations were interested in getting together for a POCUS registry, I think it could do a lot of good.
Yeah, that's wonderful. The butterfly itself, stores all the data. So as we scan with the butterfly, they have proprietary or jurisdiction over their data. I just wonder about that, since they're storing it already.
My understanding is that, so one, just to clarify, I have no financial relationships with any ultrasound device manufacturers. My understanding is that the Butterfly has had trouble gaining any foothold in Europe because of that specific issue. Their ownership of data has apparently had some conflict with European medical law. Yeah, I may be mistaken on that, but my understanding is it's had trouble finding a foothold in Europe. It is very popular in the U.S., and I can tell you that a lot of the docs in Seattle, as well as a lot of the critical care docs that I've been communicating with, have it. It is one of the cheapest handheld ultrasounds, and so they are collecting that information. Whether or not these images are going to be good enough to actually get useful analysis out of, besides bedside clinical decision making, is going to be hard to say, because not every person who's going to be handling this is going to be critical care echo. Some of these people may be doing ultrasound assisted physical exam or very basic POCUS, and some finding that might be predictive might be something like, for example, like longitudinal strain, which is not going to be something that you can see on a Butterfly.
Right. Interesting.
Yeah, well, it could be, but in most cases that will be difficult, and a lot of POCUS protocols don't involve apical 2 and apical 3 chamber assessment, so it'll be very difficult to do at least a complete strain analysis.
Right, right. In the prior H1N1 flu, when they looked back, there was a study published in Nature. They found the only thing was RV dilatation that predicted amongst the echo findings. So that's why I was just,
and that does make sense. And I would guess we'd find the same thing, given the worsened lung function probably leads to more RV dysfunction.
One thing that has been described a little bit differently with a lot of the stuff at least in Seattle, is that it's often not an issue of being able to maintain gas exchange. So in H1N1, a lot of these people died of severe ARDS. What we're at least seeing from Seattle, and what's been reported out of some of the sites in Italy, is that a large number of these people are actually able to maintain gas exchange, which would suggest it's not as bad of a I guess pulmonary disease as it is multi-organ. And so we may not see that same sort of presentation, because this is not the same sort of presentation as H1N1.
Right. Yeah, they're finding that the compliance is okay.
Yes.
Right.
Yeah. That's what I've been told.
Yeah.
So it's still early days, and it seems that POCUS may help with the workflow so that we can triage. We're not sure whether POCUS is useful in predicting demise. Would it be helpful in ongoing monitoring?
I can tell you at least the Italians are using it to help make assessments on fluid status. Now, there's a lot of controversy on that, because as people delve deeper into that area of literature, they realize a lot of people make decisions on fluid status using incorrect criteria of POCUS, but still they're using it for assessment of fluid status. And as people are recognizing that some of these patients end up having, easily treatable problems such as pericardial effusion or pulmonary embolism, which is not exactly, a great thing to have, but can be treated with, thrombolytics. The value of having POCUS to rapidly make a diagnosis in a critically ill patient who cannot go to CT scan or cannot go to get any other advanced imaging, or even, disruption and moving them to the cath lab may be, fraught with danger. There's a big value in having a test that can be done right at bedside.
Right. And so in the acute setting, it's things like pulmonary embolism and pericardial effusion from a cardiac perspective, as well as fluid status and B lines in terms of looking at the lung. But we're not quite sure about chronic findings such as cardiomyopathy in the role of POCUS, because that's more near the end of the course. Would that be a good assessment?
I suppose, again, I don't have any direct, experience with this, but this is what my colleagues in Italy and Seattle are telling me.
I think that there will increasingly be a role too to monitor pre-existing disease and what exactly goes on with it in the setting of the infection, and whether it's sort of a direct viral effect or whether it's a multi-organ system failure effect or what's going on, being able to sort of produce some kind of assessment of cardiac structure and function during the course of disease, especially in patients who already have dysfunction going in, may prove actually to be quite beneficial.
I can tell you as an intensivist, I would find this extremely useful. If I could even see that someone's EF suddenly dropped, it would change my at least vasoactive medication therapies. So I think, like, regardless of whether or not that's the right thing to do, it would definitely change how I manage that patient.
Yeah, and I just want to make the point that, you know, we should view this as something that we all support each other in, not only in understanding the fear that people have in regards to this, but also finding ways to be supportive, and whether that is image review for people who may be good at scanning but are a little shaky on the interpretation, or, you know, being willing to be there to overread images, being willing to kind of offer even remote guidance and scanning with iPhones or some products that are actually available to be able to do that. We all need to be supportive in the midst of this, and do everything we can to help provide the best care for our patients and also the most protection for us.
I think that's a great point. This really is a time for the ECHO community and the POCUS community and the critical care ECHO community to come together and provide the best care. And the document that you have generated is very timely. So we want to thank you for putting this together and leading the group. I just want to end by mentioning that the guideline is now available online at onlinejace.com. So I ask our listeners and our readers to delve into this guideline. And I'd like to end by thanking our guests who participated in this podcast today, as well as the audience members that participated in the questions. Thank you, everybody.
Thank you very much.
Thank you.
Thank you.
Everyone be safe.
You
Thank
too.
you.